So before I start talking about the medications, I thought it would be helpful to remind ourselves about the journey that carbohydrates take in our body once we consume them as food or drink. So after they are digested in the stomach and the small intestine, they are absorbed and they come into contact with the lining of the small intestine, where important hormones start to be secreted. So the GLP-1 is secreted by the L cells of the small intestine lining, and the GIP is secreted by the K cells. And these are very important and crucial part of the metabolism of glucose. So together, they act on the pancreatic beta cells to promote their proliferation and secretion of insulin. They inhibit the production of glucagon by the alpha cells. And importantly, they slow the gastric emptying and give our brain a sense of satisfaction and fullness. And by these effects, they help in reducing the blood glucose after it rises after absorption. So it would be not surprising after we know this and we know what is the main pathophysiology of type 2 diabetes, which is insulin resistance, that the oral hypoglycemic and agents and insulin work in these mechanisms. First, they could improve the sensitivity to insulin, and that's how metformin and pioglitazone work. Second, they may work by increasing insulin availability in our circulation, and that could be directly by providing insulin as subcutaneous injections, or by using oral hypoglycemic agents which promote the secretion of insulin from the pancreas. And that is how the sulfonylureas work, and partly how the new agents, the GLP-1 agonists and DPP-4 inhibitors work. Then another mechanism is by delaying the delivery and absorption of carbohydrates from the GI tract, and this is another mechanism how GLP-1 agonists and DPP-4 inhibitors work. Finally, there is a group of medications called SGLT2 inhibitors, and these work by increasing urinary glucose excretion. I'll take you first to the beginning of the management of type 2 diabetes, and as my colleagues Kate and Teresa alluded to, it starts from diet and lifestyle modification. And this is a copy of the latest American Diabetes Association guidelines published in April. And you can see that at diagnosis, the first message is diet and lifestyle management and setting an appropriate HbA1c target for your patient. Because we all know that a 25-year-old diabetic has a different target from an 81-year-old diabetic. Then we would look at the HbA1c at diagnosis. And if it is less than 9% in the old units, which is 75 millimole per mole in our new units, then consider monotherapy with metformin in addition to diet and lifestyle modifications. But if the diagnostic HbA1c is higher than 75, then we have to consider dual therapy from the start. And I will move on to dual therapy in the next slide. However, it is important to recognize very high HbA1cs and high blood glucose levels at diagnosis so that we can start talking about insulin and preparing our patients for treatment with insulin, because we know if the HbA1c at diagnosis is more than 86 millimole per mole, or if their random blood glucose is more than 16 or 20, then lifestyle, diet, and orals will take a long time to bring them down to the target range. So we have to introduce insulin early and help them through their journey until such time as they can manage with orals, and we can either withdraw it or they continue on it with a healthy outcome. So if we look at the old guidelines with the dual therapy, you could probably remember that after metformin, we have a list of oral hypoglycemic agents we can choose from based on the patient's clinical characteristics and also their preference. But the new guidelines have introduced an important point in the choice of the second oral agent after metformin, and that is the cardiovascular disease, prevalence, or risk. And that follows what happened with our experience with rosiglitazone and pioglitazone, especially rosiglitazone, which a few years back showed that it increases the risk of cardiovascular disease and heart failure. And therefore, about 4 to 5 years ago, the FDA and the similar regulatory authorities in Europe introduced a new prerequisition for the approval of any new oral hypoglycemic agent, and that is the medication should be either superior or at least not inferior to placebo in cardiovascular outcomes, so that the same bad experience is not met with rosiglitazone. And therefore, if your patient with type 2 diabetes has used metformin and does his diet and lifestyle modification, and you have to add a second agent, then it is important that we think about the cardiovascular risk or the presence of cardiovascular disease. Unfortunately, in New Zealand, we are limited by the oral agents who have been proven to improve cardiovascular outcomes by funding, although they are available. However, it's an important point to make note of, because as vildagliptin became funded recently, other medications we hope can be funded in the near future. Then comes triple therapy, and as I mentioned earlier, if the diagnostic HbA1c is high enough for us to think that the orals and diet and lifestyle will take a long time to work, then we have to start insulin early. And as Kate mentioned, there are a wide varieties of types and regimens, and she gave you a very simple and helpful practical start. Now, points to consider when we use our oral hypoglycemic agents. Of course, efficacy comes as an important point, but also the risk of hypoglycemia. People who have a sedentary job and an office job, obviously their risk of hypoglycemia is much less than the scaffolder who has type 2 diabetes and uses medications. Weight change with medications is important. Cardiovascular effect, I mentioned. The cost is also important. Although this is important on the public health level, it is also important for the patient's budget and finances as well. The mode of use, is it oral or subcutaneous, bears an effect, and also whether the medication is safe to be used in renal impairment, whether the dose needs to be adjusted, and there are a few other considerations. So the first oral hypoglycemic group of medications I want to talk about is the glucagon-like peptide or GLP-1 based therapies. And these include two groups of new medications, the GLP-1 agonists and the DPP-4 inhibitors. And the advantage of these medications is that they do not usually cause hypoglycemia unless they are combined with therapies that can cause hypoglycemia. And by this I mean they should not cause hypoglycemia unless they are combined with insulin or a sulfonylurea such as gliclazide or glipizide. So what is GLP-1? GLP-1 is an incretin, and by this we mean it's a protein that is secreted from the gut to increase the production and secretion of insulin. And the good important point about it is that it is only secreted after a meal. So if you provide an oral intake of 100 grams of glucose and provide the same amount of glucose through an intravenous infusion, GLP-1 will only increase after the oral intake. It will not increase after the IV infusion. And therefore the risk of hypoglycemia is low, because when people are not eating, they do not have stimulation of this protein or hormone. It is produced from the proglucagon gene in the L cells of the small intestine, and it exerts its main effect by stimulating the glucose-dependent insulin release from the pancreatic cells. Another important mechanism is that it slows gastric emptying and it inhibits inappropriate post-meal glucagon release. So to promote the effect of this important hormone, the pharmaceutical companies thought about two lines of research. First, how to invent GLP-1 agonists which will strengthen the effect, or develop DPP-4 inhibitors, because DPP-4 is an enzyme which is involved in degrading the GLP-1 hormone. So if you inhibit that degrading enzyme, then you will have more effect from the GLP-1 itself. And that's basically what is mentioned on the second slide. So the GLP-1 agonists that we have in New Zealand is exenatide. Unfortunately, it is not funded. It can come in two forms, either immediate release, and both forms are subcutaneous injections, and the brand name is Byetta. You can start with 5 micrograms twice a day, and then increase it to 10 micrograms twice a day if needed a month later. The modified release is much more preferable because it's once a week, and the dose is 2 milligrams once a week on the same day. If we go back to the points that I mentioned about how we decide if this medication is the right choice for our patients or not, and related to the GLP-1 agonists, then in terms of efficacy, they are regarded as highly efficacious. They do not cause hypoglycemia unless they are combined with insulin or sulfonylurea. And they promote weight loss, which is a very important advantage for our obese patients with type 2. In terms of cardiovascular outcomes, there is no evidence to show that exenatide has superiority over placebo in cardiovascular outcomes, but there is evidence that it does not cause harm. Liraglutide, which is another member of this group of medications and available overseas, has shown that there is benefit in cardiovascular outcomes. Exenatide and other GLP-1 agonists are neutral in terms of heart failure. They are subcutaneous, which is a disadvantage. And the dose need to be reduced with chronic kidney disease, and exenatide is not regarded as safe after the eGFR reduces to less than 30. There are some common side effects like nausea, vomiting, and diarrhea, injection site reactions, and possible acute pancreatitis, but that is more of a rare risk which we have not encountered in the small number of patients who use it. Then we come to DPP-4 inhibitors, and they work, as I mentioned, by inhibiting the DPP-4, which degrades GLP-1, and therefore increases the amount of GLP-1 available for the insulin production by the pancreas. They are highly efficacious. They have moderate efficacy, not as the GLP-1 analogs, and the different members of this group are relatively equal in their efficacy. The two DPP-4 inhibitors registered in New Zealand are vildagliptin, which became funded a month ago, and sitagliptin, which is not funded. And in one meta-analysis which compared the studies which look at both, found that they both reduce HbA1c by 8 or 8.1 millimole per mole compared to placebo. In terms of cardiovascular outcomes, they are both regarded as neutral, and there is no evidence that they increase morbidity or mortality from cardiovascular disease. This is a landmark study published in 2015 about sitagliptin and cardiovascular outcomes, labeled as TICOS, and it showed, as you see from the graphs, that compared to placebo, there is no morbidity or mortality, whether in the primary cardiovascular outcome, which was acute myocardial infarction, or other cardiovascular outcomes, and heart failure and death from any cause. So it is intermediate in efficacy, neutral in weight, neutral in cardiovascular disease, does not cause hypoglycemia. There is a potential risk for heart failure, but the two agents that are proven to cause that are not widely available in New Zealand, and additional consideration will be the risk of pancreatitis. Vildagliptin is now available for you to prescribe, funded by Pharmac without special authority. It comes either by itself as 50 milligram tablets or combined with metformin in 850 or 1 gram strengths. The most common adverse effects are nasopharyngitis, headaches, and dizziness. There is an important caveat that I would like you to be aware of, and there is studies in 2009 that the combination of vildagliptin and ACE inhibitors may increase the risk of angioedema. And since many of our type 2 diabetics have a degree of albuminuria necessitating the use of ACE inhibitors, we have to be careful. It is not a strong contraindication, it is a relative one, and the risk in general is less than 0.5%. The last group of medications to talk about is the SGLT2 inhibitors, and the one registered in New Zealand, unfortunately not funded, is dapagliflozin. SGLT2 is expressed in the proximal tubule and mediates reabsorption about 90% of the filtered glucose load. So when you inhibit this enzyme, then that amount of glucose will be out in the urine and not in the blood anymore. However, the ability to lower blood glucose is limited by the filtered load of glucose. And they do not usually cause hypoglycemia unless they are combined with insulin or sulfonylureas. And because they are basically diuretics, they improve blood pressure and weight. There is an important note that they can cause DKA, and that can happen with normal blood glucose levels, not with high ones. So patients should be educated about that and advised to seek your attention if they started to have symptoms. Empagliflozin and canagliflozin, which are not available in New Zealand, have proven improved cardiovascular outcomes, and therefore they are more advantageous in people with cardiovascular disease. Just this month, a study was published in the Journal of Cardiovascular Diabetology looking at dapagliflozin, which is the agent registered and available in New Zealand. And it showed that after 6 months of dapagliflozin, the EE ratio, which is the marker for diastolic dysfunction, improves significantly. They also looked at the left atrial volume index and the left ventricular mass index and BMP, and while they found statistically significant improvement in the first two, they didn't in BMP. But without giving up, they went and analyzed the data with BMP levels higher than 100, and they found that there was a significance. And there is a big trial underway called the DECLARE TIMI 58, looking at the cardiovascular outcomes of dapagliflozin. My apologies for taking more time than allocated. Hope you had benefit from this, and thank you.